So the economic outcomes in 8045, this was prospectively planned, so in fact we've got really pretty accurate information. The pharmacoeconomics are such that the outcomes favor bevacizumab over cetuximab, mostly because of the cost of drug and the infusion time, and the frequency of the way the drug was used, of course, in 80405 was weekly cetuximab. But what I would say is that we are reanalyzing it by sidedness. Let me put it that way, because in fact, it's now clear that many patients got no benefit from the cetuximab. As we move forward, if we're going to be picking our patients differently, we need to analyze it differently to see how it plays out. However, the analysis that Deb Schrag has done would clearly suggest that it's a bit more cost-effective to use bevacizumab. In my opinion, the other compelling argument against cetuximab is the rash. We had an embedded quality of life instrument in 80405, which we presented 2 years ago. Basically, patients despise the rash, at least in the US, they do not like it. The disfavorable results in terms of quality of life were dramatic in that subset, although overall patients did not have a statistically different worse performance or quality of life with cetuximab. And that's a little bit of a perversion, and the reason undoubtedly is that patients know that if they get a bad rash, they're likelier to be benefiting from the therapy. So what we think happens is they may have a bad rash, but they may worry less about it because they think the drug is helping them. And that sort of saves the case, because otherwise the unpleasantness of the rash is substantial.